All right, let's go. For us, it is afternoon. Good afternoon, Loris. How are you?
I am well. Cleet, how are you?
I'm okay, and thank you for joining us. Um, what we are about to do here is first of a series of four, and we're going to kick it off with Loris. Um, and a little bit about Loris Friedenfelds. He is 45 plus years of security experience. I got it right here in my notes, Mr. Friedenfelds. But what interests me the most is, and why I would have him come here is he has 2 decades of campus and healthcare experience. Just as a sidebar, I never forgot it, but Loris famously shared with me years ago, Clete, if you ask me what would I want from a visitor coming in here, I would want blood samples. And that stuck, that spoke to his mindset, that stuck with
Yeah.
me. I never forgot it. So,
Yeah.
um, that signaled to me where Loris was coming from. But no, seriously, thank you for joining us, Loris. It is always a pleasure to speak with you. This series that you are helping us kick off is going to be with people like you that have been many places. And that's important because no two hospitals are the same, no two systems are the same. The experience of your colleagues and former colleagues is going to vary if they're in downtown Chicago or if they're in Carbondale, Illinois. And you and your colleagues that we're going to have in this series can help us kind of speak to all those things. When I'm asking questions that I'm aware of, you can kind of chime in from all these different doors that you have walked through. So thank you for sharing that experience with us. I'm sorry, quickly, you are VP of
Security risk and consulting at
at
Telgen
Delta.
Engineering.
Yes, sir.
Yep.
Thank you very much. Thank you very much. And available for future times to walk through others' doors so that you have more experience to share with us.
Yes. Yeah. You indicated, I've spent 2 decades working in the security operations world, and I've spent now about 2 decades as a consultant, working with various healthcare organizations. So I've got both internal knowledge, internal experience, as well as an ability to take a look at it from an external third party perspective.
That's exactly why we want you here and looking forward to some of your colleagues that are going to join us. And we're going to be informal. We're going to put it right where the goats can get it, as they say. Um, Not necessarily rapid fire because we have some high points to hit, but I want to hit you with some things, make you dig in a little bit more. So let's get right into it if you're ready, Loris.
I am ready. Sure.
And our series is going to be around physical identity and access management in hospitals. I do want to be able to get into um, some of the bad stuff that you see. I want to be able to also highlight some of the good things that you see, because
Mhm.
again, your colleagues can maybe take away some of these practices. Um, and then some of those stories might be a little bit ugly. So the good, the bad, and the ugly, as they say.
The whole gambit.
Yep.
Yep.
And so setting the stage, and let's say typical. I don't want this to necessarily be good, bad, but setting the stage, why don't you walk us through quickly the physical identity life cycle in a hospital? And I know that's different, but it's gonna sound better coming from you. As an employee here at Right Crowd, I was on board at one time. There is no badge for me, et cetera, et cetera. But it's a vastly different environment in healthcare. So why don't you walk us through what it's like to be just on board in healthcare?
Well, it's a really loaded question because, quite frankly, healthcare is a symphony of different people coming into that organization, that institution, that facility. So we can take, for instance, employees, and they're onboarded through perhaps something like an Active Directory. They're included. They've got their IT information and so forth. And so what ends up happening is that you start the process of getting them authorized, both in a logical access control world as well as a physical access control world. In the physical access control world, you're going to come down, and typically we're in the basement. All of us guys here and all of us gals, who are security
Uh,
folks and directors, know we don't get the penthouse suite. So you're downstairs somewhere, and you're getting a picture taken. You're getting your identification verified through either some sort of a system, the Active Directory or something of that nature.
Uh-huh.
You're getting your access levels, initial access levels, all generated, and then you're given a card and you're processed through. That's just one of many different ways, or many different types of people that need to have their identity verified. For instance, I've seen so many reports of people getting into hospitals that don't belong. Um,
Mhm.
it's because perhaps we're used to this white coat as perhaps an identity kind of verification. If you wear a white lab coat, you're authorized to come in, and that's been historically why or the means of how people were identified. It's now changing, so that employee needs to be verified that that in fact is a good employee. But there's more to that. There's the contingent workers, the contractors,
Uh-huh.
the students. If you're a academic facility, you're going to have students coming in through, and each one of those has a different process. It's a symphony. It is difficult to manage. I know every one of us sitting here listening to this can appreciate how complex the method is to ensure that the right people come into your healthcare institution, and I'm not even touching the visitors yet.
Yeah.
And that's
Yeah.
a huge part, and
I was
that's
also going to say, Loris, that you're also speaking about one hospital. We got one of our buddies here locally where he's got
uh
several hospitals, and that process you just outlined, he has to start all over at the next hospital.
Well, you have to even look at the complexity of the situation where you might have been the security director of an organization that has acquired another hospital, like you said,
Okay.
and their systems are disparate. It's a totally different concept, perhaps maybe a different system at a different location, and yet that C-suite wants to be able to go from one building to another without any kind of problems, any kind of having to carry 6 or 7 different cards, kind of a thing. So yeah, it's not an easy task, and quite frankly, hats off to all of us who have experienced
Uh-huh.
it and have had to work through the complexities of these kind of things.
Yep. And we're just talking onboarding. Now we get a little bit to the ugly side of things.
Yeah.
Let's talk about, we'll say offboarding, but sometimes these come, best case scenarios, these come with a schedule. Like you said, contingent workers. We know we have that doctor for 6 months, et cetera. So we have a schedule we can use. Sometimes, this is an unfortunate incident that happens very early on, and now we need to do some type of immediate termination. So with that whole process you just outlined, how does that work when now we're talking about a termination or an
Sure.
offboard?
Sure. So again, it's easier when you have an Active Directory type of interface with
Mhm.
an employee kind of a thing. That's generally usually an overnight kind of process. You process the terminations that night, kind of a thing. If they're timely, if they're reported timely, that's always the case, kind of a thing. That a lot of activity occurs, maybe operationally sitting in front of the desk with the employee, but the paperwork trail doesn't catch up, so you always have
Mhm.
to make sure that that's taken care of properly. But the biggest problems are typically with those contractors and those contingent types of workers. They're generally given a predicted time frame. XYZ trade is going to be working here for the next 3 years.
Mhm.
We're building this building. So they will typically put in a term date for the end of that contract. But that person may have been terminated because of some issue really earlier in the process. And
Okay.
you don't want to wait 3 years for that person's access privileges to be revoked, you want to do that right away. So those are typically manual and very labor intensive kind of a concept. So yes,
Good to hear
it's
you say that. It's good to hear you say that you have seen manual. I know but I'm asking very pointed questions, obviously, when I'm
yeah,
talking to hospitals. So I know that not very many people tell me about any layer of automation outside of what you described with the onboarding. With
yeah,
onboarding and offboarding of the employees. You and I actually were talking about a local client not long ago where nothing on the contractor side is connected. That's all manual. Every one of
sure.
those contingent workers, it's all manual. um, Another thing one of your colleagues told me is that this kind of stuff is a Monday through Friday thing. Would you agree with that? These are, when it's done by, gentlemen, ladies and gentlemen in the seats, it's a Monday through Friday thing, and it's very easy for things to happen on the weekend that don't get picked up.
Oh, of course. You have a situation that occurs on a weekend, and you know this as well as everybody else does. You may not have the all the support people working there on the weekend, so you're going to end up waiting until that Monday or something like that. I can't tell
Uh-huh.
you how many times we came across circumstances where I've seen where people have had to be terminated because of some negative information or something of some national kind of issues and so forth. When the researchers are involved and so forth.
Mhm.
Uh, it those things kind of always happen at 5 o'clock at night on a Friday. you know, and so there I am sitting, or my staff are sitting there doing something at the end of at the end of the day. But if they're already gone, you know. You can sometimes remote in, but not everybody has the capability
Ah, yeah.
to do a remoting in kind of a thing. And so there's challenges. The biggest challenge has always been, and I've seen this with audits and at various institutions, that the audits say that we're not terminating, we're not getting rid of people on a timely basis. That's usually the biggest ping that an audit will hit us for, and that's something that we struggle with. Try to work and become more efficient, create means of being able to accomplish that.
You are absolutely hitting the nail on the head, and I'm taking notes because, again, you are helping us set the stage for these different things we're going to dive deeper into. Audits. So we are absolutely going to talk, have an entire session around audit and compliance. So
Yeah.
this is perfect that we can kind of set the expectation high level. What does it take to get somebody onboarded? I think auditing comes into your example when you spoke about the contractors. They have a 3-year contract. Well, do you go in your access control and set that 3 years from now and leave it alone? I know some people that do. I'm sure you've bumped into it.
Well,
Um,
and I think that sometimes you have to take a look at it and see if you could set some sort of a 6 month or some sort of a earlier type of check-in. We used to do that pretty much on a regular basis at one or two of my institutions, where we would check in every 6 months and send a list to the sponsor of that
mhm.
contract and say, please tell me if these people are still here. And quite frankly, those are important because they have to be compliant with things like vaccinations and training and so forth. So if they are there, they may have to retrain or get their certifications or their vaccinations, kind of a thing. So yeah, there's again, it's becomes a labor intense type of a situation.
Oh, well, you answered my question. I was going to ask, in your experience, those, when you're talking about sending it out, like since you want to go every 6 months, that you don't end up with the entire contractual date, are
Yeah.
those all going to be manual? And I guess they are because you said they're pretty labor intensive.
They are labor. Yeah, they are labor intensive, and quite frankly, yeah, you definitely want to set some sort of reasonable time frame. But again, if somebody's being terminated for cause because of some issue that is very detrimental, their behavior was problematic, even 6 months is too long to wait. It's you want to do that right away, and you hope that the sponsor and hope that the people that are working with that contractor actually remember and do pull the trigger on getting you that
Uh-huh.
information immediately, kind of a thing.
Um, and keeping with our theme, of course, no names, but does anything come to mind for the best, physical access management that you've been able to witness, like in the best case involving, integration and really trying to be at the forefront? Does anything come to mind for some of the best stuff you've seen?
I think what I've seen, and I actually am very much a proponent of that all healthcare institutions start looking at, is management of the visitors, the people that are coming in to see the patients.
Mhm.
I've seen situations where the nurses they either go on strike because they want
Yep.
pay, or they want a other things, but they throw in the fact that they don't feel safe, and then when you dig into I don't feel safe question, you realize that it's almost always the visitors that they're concerned about, the people that aren't well identified in the process.
Mhm.
So I've seen where hospitals are now implementing visitor management into their total identity and access control concept.
Mhm.
It helps the staff feel safe. They don't care if you're going to throw five more security officers out there, or five more cameras, or five more card readers. They just want to know that you are doing your professional best to protect them in their environment, and how you do that. That's the means for us to determine what's the best way. And like I said, the visitor management concept has been the biggest and most important thing. They enjoyed being part of, and we've talked them into being part of the security layers of protection. You
Mhm.
know how we all know those layers. In cases where I've seen this, the people that are issuing the badges are layer number one. They're the ones that are vetting. Okay, Cleat does have a right to see Loris in the hospital. It's a
Mhm.
privilege, not a right. So he has that privilege. It's not been revoked. The second layer is typically a security person, checking to make sure that person is going to wear that badge as they
Walk
traverse
the
through the
floors.
hospital. Yeah, walk
Yep.
the floors of traverse. And then the nurses are willing, and I've seen this happen where they're then willing to be part of that last layer of protection, saying, "Okay, we see this. That person doesn't belong in that room, or that person doesn't. He's trying to get into some other patient's rooms." A lot of issues occur because unfortunately visitors become they look for opportunities. And crime is of opportunity kind of a situation, and so
Mhm.
they'll go into other people's rooms, and so nurses are a big part of that, and they're willing to do that if they know that you have done an effective job at the other layers in front of them.
Um, I'm looking now. We're running down, so I want to get to some more hard ones.
Yeah.
Um, this is a hard one, but again, I want you to be candid. This is, your colleagues you're speaking with. Um, you have described many laborious tasks, the manual, time consuming, et cetera. They can get multiplied out, like we said. So, why isn't there more automation of these tasks? And of course, this is your opinion, and I know it's going to change based on who you visit. But why isn't there more automation and integration in this process, which obviously increases security?
Yeah, and really what it boils down to, I think, is the support of the automation and support of the technology. I think that too many times we have seen, you install the technology, and then you think it's going to run like a fire alarm system. Nobody needs to touch it. Everything is great. Everything's fine. But you need to manage these things. The sexy term nowadays is AI. Well, AI is machine learning. Everything has to be taught. Everything has to be managed. It has to be, you have to keep moving it downstream to make sure that the right, um, the right kind of decisions the machine is making the right kind of decisions, and that's where the I think the failure is not supporting some of these systems, and they just end up just becoming whatever they were as they were installed.
So, Loris, one of the hard ones, and again, no names, but one of the hard ones, speaking to your colleagues and your opinion, of course, but um, why isn't there more automation and integration that would cut down on the time and the labor involved in some of those tasks you outlined?
Yeah, it's a complex kind of symphony of systems, so there's a lot of management and support that's necessary for these kind of systems, to integrate them, to automate them. It's not just like hanging a fire panel on a wall and turning it on and seeing that it works and it'll work for the next 10 years. These things, whether you want to call it AI, machine learning, they have to be managed. They have to be supported. They have to be driven so that decisions that machine is making are appropriate and exactly what you're looking for. So it takes a little more effort there, but it certainly replaces a lot of the manpower requirements if you were to look at what it takes if you didn't do that.
Yeah, I fully agree. It is more effort on the front end versus just throwing your access control in. But it's kind of like the example I heard one of your colleagues use was it's like TSA.
Yep.
It wasn't there, but once it was there, you understand the need for it. It's absolutely necessary and it makes everything better behind it. So same thing with
Yeah.
this concept.
Yeah, we're growing. This is a growing industry. I started out, it was just a simple access control system here, camera over there, and nothing was talking to each other.
Mhm.
Now we're much more complex. We're capable of doing a lot more, but it's a growth, and it takes time for people to understand how to manage that and work that.
Um, Last one, and we're going to wrap up.
Sure.
Anything come to mind when we're talking? My spiel is that there is. You and I have done sessions on visitor management before. It's a necessary evil, just kind of like I won't use the word evil, but it's a
Yeah.
necessary process, just like TSA.
Uh-huh.
There is no ROI, and you and your colleagues have to compete with ROI all the time. I understand it. There's no ROI with visitor management. um, there is an ROI when it comes to adding some of this automation to these processes that you're speaking about now. So, um, for your colleagues that struggle trying to make this happen, any advice you can give them, some of the things you've left them with when you go around and do your surveys and assessments, to help them move the needle? Because one of your colleagues famously told me, "I'm up against the MRI, Clayton. The MRI is going to make $1 million a month." So
Yeah.
what do you tell your colleagues to help them quantify these risks?
I love the relationship that security directors have with risk management and legal folks. I would strongly recommend that everybody pair up with your risk management folks because they understand that not all hard number ROIs drive what
Good
the
point.
institution should do. You should want to be at the enterprise risk management table and explain, that the engagement of the nursing staff can be improved. You can become more efficient, and if we are able to give them an environment where they feel safe. You can talk about the types of risks that exist and compare it to the folks that are also addressing, financial and IT and logical types of risks, and let the senior C-suite folks make good decisions based on good hard information and good information that's available to them. Because if you're sitting there and just waiting for security to respond to an incident, you're not proactively
Mhm,
preventing things from happening.
mhm,
And so you need to have some visibility, and that's really, I think, in my mind, the key thing.
Very good point. I'm actually gonna use that in the future. I'll give you credit, of course, but pairing with risk management, that's one of the ways they can help
Yeah.
move the needle, pairing with risk management.
Yep.
Um, Loris is available via LinkedIn. Loris Friedenfelds. He has walked many halls of healthcare, of hospitals, and he's not done. So he's available to walk more halls if need
Yep.
be for security risk assessments. Thank you for joining and sharing, Loris. And this was a great way to kick off what we have coming up.
I'm
Very
glad to
excited.
help.
Oh, thank you. Thank you very much, sir. And I'm very excited for um, what we have coming up in our second installment is because I've never presented with him before. Know him, great guy, Paul Sarnice. And again, you helped set the stage for where we are now, but with Paul Sarnice, we're going to be able to dig pointedly into audit compliance and reporting. So, you kind of help us kick this off. Thank you very much, Loris, for setting the stage. And then we're going to dig down personally into each one of these. And we'll do that next with Paul Sarnice.
Sounds like you've got a tremendous group of professionals that will help others get better at their job.
That is the intention. And thank you again, sir.
You bet. You bet.